right. So good afternoon, everyone, and thank you for joining us today for our first workshop for this rulemaking. I am Amelia Boyd and the program manager for the commission and the organizer for this webinar. This meeting is being recorded and will be made available sometime later this week. The documents which will be discussed here today are available on our website, which is wmc.wa.gov. Attendees, please remain muted unless you are speaking. If you have a question or comment, please use the raise hand function or the chat. And I will begin the roll call of panelists and staff. When I call your name, please introduce yourself. Great. Let me get over to my people. So Marlon, if you would go ahead and introduce yourself.
Good afternoon, Marlon Basco. I'm a policy analyst with the Department of Health, and I support Amelia with rules.
Thank you. Marissa?
Hi, everyone. Marissa Courtney, licensing manager for the Washington Medical Commission.
Dr. Curry?
Diana Curry, medical commission member, OBGYN.
Thank you. Kyle?
Good afternoon, everybody. My name is Kyle Kiernan. I'm the executive director for the Medical Commission.
Mr. Lopez?
Good afternoon. My name is Ed Lopez, a PA commissioner and a hospitalist.
Micah?
Good afternoon. Micah Matthews, Washington Medical Commission. I'm the Deputy Executive Director.
Thank you. Let me get back to my... Okay, so Dr. Domino, if you would introduce yourself and then begin the script.
Hi, I'm Karen Domino. I'm chair of the Washington Medical Commission. Here's my script. Good afternoon. My name is Karen Domino, and I will be the presiding officer for this rules workshop. Today is Monday, October 14th, 2024, and it is now 2:33 p.m. The meeting is being held via Teams webinar and in person at the Department of Health located at 111 Israel Road, Southeast in Tumwater, Washington. The rule being discussed today is regarding the new profession, Certified Anesthesiologist Assistants. Ms. Boyd, please give an overview of the rules process and our proposed timeline for this rulemaking.
Thank you. So since this is the first workshop for this rulemaking, we're going to do a little overview of what a rule is, why we're creating this rule, and then, like Dr. Domino mentioned, we will talk about our proposed timeline. So a rule or regulation is a written requirement that applies broadly across a group of individuals or entities that enables, guides, or directs them to do something or prohibits them from doing something. Specifically, a rule establishes or subjects individuals or entities to penalties if it is violated, is a qualification or requirement that gives a benefit or privilege, sets qualifications or standards that an individual or entity must meet to get a license or permit, or set standards that must be met before a product or material can be sold. So why are we creating this rule? We are creating this rule because it's based on Senate Bill 5184 and is important for several reasons. The bill formally recognizes certified anesthesiologist assistants, or CAAs, as licensed medical professionals within the anesthesia care team. The bill mandates the WMC establish rules to govern the practice of CAAs and clarify specific items in the bill. Items such as renewal, CME requirements, and military spouse licensure were not addressed in the bill, but are standard components of WMC regulatory license structure, so must be defined in rule. Washington is facing a shortage of anesthesia providers, leading to increased wait times for critical care. Implementing rules for CAA licensure can help alleviate this shortage by expanding the workforce and enabling CAAs to provide essential anesthesia care. The bill aligns with practices in 20 other states where CAAs are already recognized and licensed. Creating a rule will help standardize practices across states, allowing for greater consistency in training, practice, and patient care. with the integration of CAAs into anesthesia care teams, patients can benefit from improved access to skilled anesthesia services. This can lead to better patient outcomes and increased efficiency in healthcare delivery. The proposed rules will provide a clear and comprehensive framework for how CAAs can be integrated into existing hospital and anesthesia group structures while allowing flexibility for different care models. This is crucial for tailoring the integration to the specific needs of each facility. By establishing rules based on the bill, the Commission can create a clear and comprehensive framework for CAA practice in Washington. This clarity will benefit hospitals, anesthesia groups, and CAAs by outlining expectations and responsibilities. The rule will provide a legal and professional framework for CAAs, which can enhance job security and professional recognition. This may attract more trained professionals to the state, further addressing workforce needs. The bill ensures that supervising anesthesiologists maintain authority over CAAs, promoting collaborative care models that leverage the skills of both anesthesiologists and CAAs to enhance patient safety and care quality. Establishing a licensure process helps to ensure that CAAs meet specific educational and training standards, which can enhance public trust in the healthcare system and ensure patient safety. Overall, creating rules based on Senate Bill 5184 will provide the necessary framework to support the effective integration of CAAs to the healthcare system, ultimately benefiting both healthcare providers and patients in Washington. And then just some important information to keep in mind. Senate Bill 5184, codified as Chapter 1871D RCW, is now, as noted earlier, the bill mandates rulemaking for CAAs, so the WMC must proceed with this process. If you seek changes to Chapter 1871D RCW, please contact your legislative representative. When providing feedback on the draft language during this workshop, please keep in mind that the WMC serves as the rulemaking and disciplinary authority for MDs, PAs, and now CAAs. We do not have jurisdiction over other healthcare professions. For changes to WACs governing other professions, visit the Department of Health's website at doh.wa.gov for contact information. And then here is our proposed rule development timeline. We hope to complete the workshops by the end of this year and then request to initiate the proposed rules or the CR 102 in January at the Commission's business meeting on the 10th. And then we hope to have the public hearing in May of next year and then the final adoption sometime in August next year. And the rules would be in effect probably 60 to 90 days after the final rule is adopted. And that is it for me, Dr. Domino.
Great. Ms. Boyd, one thing I did notice Dr. Chung is somewhere in the audience, and I know since he's a commissioner, I just want to be sure he is able to participate in our discussions.
I'll get you moved
anyway,
over.
Yeah, thank you. Are there any questions regarding the rules process that Ms. Boyd outlined?
Dr. Domino, no questions, but similar comment about Heather Carter being in the attendees and not in the panelists.
I will go move her as well. Thank
And I'm
you.
not sure if Dr. Trescott was also listed. I'm not sure if she's on that list or not, but.
Okay, I will get those two folks moved over for sure. Hold on just a second.
Okay.
Yeah, I've got Dr. Chung moved. Heather, nope. Okay, I don't see Dr. Trescott. She may not be attending today, but.
Okay. Well, should we have Dr. Chung and Heather introduce themselves before moving on?
Dr. Chung, if you'd go ahead.
Hi, thank you. I feel like I was holding my breath this whole time. Jimmy Chung, General Surgeon, District 1 Commissioner.
And this is Heather Carter. I'm an Assistant Attorney General and Legal Advisor for the Commission.
Thank you both.
All right. The next item is the presentation of the draft language, which is included in the meeting materials. As this is the first workshop and the initial discussion of the draft, it's very, very unlikely that we will cover all 37 pages today. We will pause the discussion at 4:15 to schedule additional workshops. So please, commissioners, do look at your calendars. I know I will be looking at mine at that time as well. All right. Ms. Boyd, I think we can begin.
Okay, so as we've mentioned several times, this is the first workshop. This is the first time that we are seeing this draft language. It got posted on Friday, I believe, or maybe Thursday, I can't recall. And so we've had a little bit of time to look at it, the commissioners and the public. So we're going to kind of go through this by section. So if you have comments or questions about the section that we're discussing, feel free to raise your hand or put that in the chat if you would like. And then commissioners, your job is to look at each section. If you have comments or questions or things you want to change, the document that's on the screen now, I can do live edits on that document as we're working through. And then if you have questions about the bill itself, Micah can certainly answer those for you. He is very familiar with this particular bill. So away we go on definitions. Does anybody have any initial questions or comments about the definitions in this section?
I thought this section seemed very straightforward.
Just a quick question for those who are more familiar, I guess. Is it standard language to say board eligible alone, or is it customary to say board eligible or board certified? Or is it adequate just to say board eligible?
Dr. Chung, the definition, I believe, is directly taken from the statute. I'm going to look and double check just to make sure. Yeah, so it says an anesthesiologist means an actively practicing board eligible physician licensed under Chapter 1871, 1871B, or 1857 RCW, that's DOs, who completed a residency or equivalent training in anesthesiology.
Okay, I was just curious because in some documents, it may be called out twice. So I just wanted to make sure that's standard. Thank you.
There was some kind of comment that flashed by in 1 second.
Yeah, so number 6.
Let's see, it's number 6. They're asking if there's a reason why CAAHEP is not mentioned specifically when it is later in the rules.
What is that?
Let's find out. Council on Accreditation of Allied Health Education.
I think I can speak to that. So in doing the research of on how these programs get accredited, I believe what I came to was there was a delegation to ARC. Sorry, I lost the definition wherever it went.
Oh, sorry. Yeah, I jumped away.
No, no worries. Yeah, so ARC AA is what it seems to be the CAAHEP delegates its accreditation programs to and relies on that. If that's not an accurate understanding of how that system works, obviously we're open to feedback on that.
Mhm.
That being said, it's very similar to PA programs. They have ARC PA as their accrediting body for their educational programs.
Did you have anything to add to that, Kelly Camp? They may be typing. Oh, they said no, thank you. Thank you for the clarification. Okay,
And I am remiss to know where in the later of the document CAAHEP is located and what its usage is.
and that's what I'm looking for now.
All right.
Okay, so it is in 25. And 125. Okay, it's 125, 1B.
Okay, I think I know why there's the difference. This language was taken from the PA WAC or the PA rules. And so in the PA rules, it states that versus what we're doing in these rules. The intent of going ARC AA or ARC PA is a more direct line to the actual accrediting body. And so that would be an equivalent of calling out ACGME or something like that.
So does that mean we need, because this does also reference this WAC 918055, that is a PA WAC.
Mm-hmm.
So do we need to change this?
Let me go look at that WAC and see what the actual language is.
Seems like it should be consistent
I agree.
because it's about graduating from via program. So how it's accredited should be probably the same.
That one's about practice agreements. 055 is.
We can change it to match ARC PA here. It's not specifically listed as a reference in the PA WAC. It just simply says they have to complete a commission approved program.
So do we need to change B to say something completely different then? If so, please lead me
It would
through
just
what you would
be
like it to say.
it would just be accredited by ARC PA and match the same language as the definition instead of the CAAHE HAC or whatever it is.
So if I just remove this, does that meet what you're trying to do here?
No. So, because in B, it's specifically referencing that the Committee on Allied Health Education and Accreditation Commission. And so we'll need to replace that with the ARC AA reference.
Oh, that you referenced earlier.
Yes.
Okay. In the definition. Okay. So since we define it, I can just put ARC-AA here, right?
Correct.
Okay. And then I do need to delete this part, correct?
And to respond to D Bender, by changing the B, that is exactly what we're doing, is making sure that the PAs, should they go through an AA training, would be having the exact same standard as a CAA. And I think you can delete as defined in WAC, da 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 da.
Blah, blah. Gosh.
Yep.
Amelia and Micah, in
Yes.
definition, in B of the definitions, we say the ARC AA accredited education program specifically designed for training anesthesiologist assistants or other substantially equivalent organizations approved by the commission. Do we need to repeat that language here for consistency?
I mean, I don't feel strongly about it. I would defer to Heather or Kyle on this one. It feels like more of a legal question.
For consistency, I would either use the term, you could just use the term here, graduated from an approved, accredited, or just commission approved program, because your definition is gonna then come over with all of that language. But you
Okay.
you could add in or substantially equivalent.
Sure.
It's up to you.
So which do you want? Do you want this language or do you want different language?
I would delete it.
I mean, I think that just by saying or commission approved program, you know.
Oh, I see. So, okay, this is similar to our, so the ARC AA is the program, but the CAA HEP is the accreditor. I'm gonna flag this section.
Sure. I mean, from a consistency standpoint, this is how we approach the PA statute as well, or the PA rules.
We may revise this when we get to this again. So let's go back to the definitions. I am so sorry for people that have visual issues when I'm scrolling. Sometimes it goes fast, sometimes it goes slow. Were there any other comments or questions about the definitions? As I'm getting back there. Also, these will be in alphabetical order when they get put into actual rule.
I'm fine with that section.
Okay. Okay. Looks like there's no other questions about that. Oh, sorry. Clicked a link and it took me off into. Okay. That's what I want. Okay, so moving on from the definition section, if no one has any other comments or questions.
Amelia?
Yes.
I'm so sorry. I hate to be totally picky, but I wanted to just call out one little thing on the definition of supervising, because I think one of the comments we got, I want to say from the WANA, the nurse anesthetist maybe, it says the medically directing anesthesiologist should be immediately available, blah, blah, blah. And like if applicable, be there for induction and emergence from anesthesia. I think that, yes, if applicable.
The medical
Is-
direction to bill, from a billing standpoint is there for induction, emergence, all critical phases, etc. It's just the standard medical direction.
That's
So I
my
thought-
understanding too, Karen. But if we have if applicable in here, does that mean there are times when they don't need to be there?
Well,
Because
I
it's not
suppose
applicable.
if applicable, I think they mean in case it's a monitored anesthesia care case, there is no induction and emergence. Those are for general anesthesia. So that would
Okay.
be if applicable, but I mean,
It's just the language where I'm just like, does this
Yeah.
mean that someone could use their judgment and say, well, even though it's general anesthesia and we're intubating them, this particular thing
I'm
isn't
worried
applicable
about
because
if
it's
applicable,
ASA1 or some,
that just scares me. I mean, or it's, I mean, our attestations say there is no induction and there is no emergence. And we attest to that. So that's why I didn't like the word if applicable.
other-
Go ahead, Deb.
That, I was just gonna say that if applicable is part of the statutory definition, so it's straight from the statute. That's what the legislature put, so.
Then
I
I
guess
have
so
to
we
keep
have
it.
to have it.
Yeah.
Thank you, Heather.
Sorry, I'm making some notes from the comments. Okay. So we're not making any changes to supervise then, correct?
There's comments about number 7. Certified,
Number 7.
sort of not certified
Oh,
until
okay.
you pass the exam.
Oh, this says a certified
It
AA
says-
cannot be one that is just exam eligible. Right. Discuss.
Micah, you know about all this stuff. Is that,
To some degree. I'm
Yeah.
looking at the definition statute right now, and
So I'll be honest, I had a little bit of heartburn over this whole part of it too, but that might reflect my lack of
Yeah.
understanding of what kind of exam happens like at the end of the program training. Because for a doctor, you're not board eligible even until you've passed your big written exam at the end of residency. So you have had some
Right.
sort of exam. So if someone could clarify that part of things, that would give me some
yeah,
reassurance.
I think we can delete as and is eligible to take. Or, yeah, so and is eligible to
And-
take, or delete that out. And because I don't believe this is, I'm looking at the statute right now. I don't believe the definition is in there.
It's not.
Okay.
So now it would read, means an individual who has successfully completed an accredited anesthesiologist assistant program approved by the commission or has successfully passed the certification exam offered by the National Commission for Certification of Anesthesiologist Assistants or other exam approved by the commission.
Shouldn't that be an and, not an or?
It was an or, so
I think it should be an and. You deleted the first and.
okay. So they have to be both completed program
Education
and
and-
pass the certification. Right. That's correct. Okay. Does that clear that up for the comments, people in the comments? Thank you. Okay. So No other issues with the definitions. Okay, so I think this language here in application withdrawals is standard for our other professions, right?
That's correct.
MDs and
That's
PAs.
our standard process.
Well, we are going to skip that one then, because if it's the same as what's in our others, we'll just move along. Okay, so this is probably going to take some time, the requirements for licensure. So do any of the commissioners have any questions or comments about this section? And then Marissa introduced herself, but she is our licensing manager, so her and Micah can field questions on this particular section.
It seemed fine to me.
Any
I agree, it
comments
was
from?
fine.
There's this comment about, again, the acronym there, ARC-AA. So whatever, we need to get those straight, whatever it is.
Right, so this one
Yeah.
is the one that's supposed to be the CAAHEP. I will do some more cleaning up of this before the next meeting.
Yeah, and I also, it's hard to even know what these initials mean. I mean, so like at NCCAA, I have no idea what that is. So I don't know if you could define it, and then maybe it's defined earlier. You know what
Yeah,
I mean?
it's
There are too
defined
many
earlier.
acronyms of things and that we don't know anything about.
I'm pretty sure it's defined in the definition section.
I think
The
the
NCAA.
NCAA was the,
Mhm.
yeah, it was defined in the definition.
And that's typically the layout of rules as we define. We
Yeah,
either
sorry, I
define it in
missed
the
it.
rule,
Yeah.
in the definitions, or we define it at the only point that we mention it. So if we only mention an acronym once within the body of the rules, we only define it at that word, lay it out, and we don't include the abbreviation. So that's how we usually do these abbreviations in rule.
Thanks.
Okay. And as we mentioned, fees will not be discussed here today. That is the last section, and it will be numbered 990 because that is consistent with our other fee sections for PAs and MDs. Go ahead, Heather.
Yeah, so in section, I'm moving on, but in section 2 right here, the second
Mhm.
sentence, I don't know if you want to create a different section for that. It doesn't seem to go with, we'll only consider complete applications, and then it's talking about people being ineligible. So
Maybe just a 3.
at least a 3.
Okay, that makes sense to me. You have any heartburn over that, Micah?
No, I just wanted to clarify that's not to pick on internationally trained folks. It's simply, as I was doing the research on this, what I found as an explanation. And again, ARC PA has a similar explanation with respect to internationally trained folks trying to go through PA programs. So it was more of a proactive, just letting people know it's not us saying you can't do it. It's the accreditation scheme.
Okay. Any other comments or questions about this section? All right, moving on to AA qualifications for interim permits. And Micah, remind me, this language is taken from the statute or one of our other?
Pretty sure I copied it from the PA statute. Again, interim permits are fairly standard all across our licensure regs. So that's where this is. Oh.
Okay. Kelly, I'll make a note of your comment. Does anyone have any comments about this section or change suggestions? Micah, do you want to address that second comment? Interim or
leave
temporary
Heather-
permits?
I will leave Heather
Heather?
to address that.
Okay. Heather, can you read the comments?
Yeah, I can see the comments.
So that's that second piece from Kelly.
Can you make a note of that and we'll look at it further and just see see if there's authority.
Okay. Is that in the bill?
As far as a prohibition,
Right.
not that I saw.
Doesn't that make it more of a barrier because we have to wait so long for the national background checks and stuff, the FBI stuff? If we
To
don't
be
have
clear,
interim
these are
permits?
so I'll explain the difference between the two. So an interim permit is for someone who finished their program but is waiting on taking the exam because of scheduling or something like that. The background check permit is one where they've already completed everything, including the exam, but the background check has not been completed yet. And just for clarification, we don't perform the background check. That is something that the Department of Health and the Washington State Patrol do. And as we found, say during COVID, it can stretch to weeks at a time. And so this is the background check section is a standard process across all of our license types that allows us the flexibility of if the background check unit is backlogged, then we are able to issue that permit and they can start work while the background check processes. They've completed all of the educational training certification requirements. It's just that one internal piece that is lacking.
Right. So, and that's how it is for MDs and PAs and everybody, right? Is
Everyone we
have
regulate, correct?
that we regulate. Yeah. So it seems weird they would remove that. Unless it's just removing the other one you were talking about.
It looks like the comments want the interim permit removed. I think if we are talking about removing the background check permit, that's a broader conversation. And I think we would probably have some process problems with that.
Okay.
So
Sorry,
I
I'm just
think
trying to
the-
note these comments.
The
Go ahead,
next
Heather.
section is the one on the background checks, and that I believe is authorized through the UDA, not the Practice Act. So I think it was authorized for all professions that health licenses. But that's not this section. It's the next one, I think.
Right. Just want to give clarification between the
Yep.
two types.
Yep.
Yeah, Micah, is this is
Thank you.
consistent with our PA rules as well for the interim?
That's correct. The PAs do
Yeah.
have an interim permit.
So it sounds like we should be consistent within our organization regarding this.
From what I heard from Heather, we're going to go back and do some research and see what authority is or is not there.
So point of clarification, if I may, I had a question. In that sentence, in the sentence, successfully passing the commission approved licensing examination, does that infer that there will be a licensing examination, or should that say certifying examination? Or certification examination?
I think you could clarify by saying certification examination, but I think we should probably let Heather do her research to find out what it is. For the purposes of PAs and now CAAs, the licensing examination and certification examination are one and the same. Not the same exam, but the same function. Sorry to clarify that. So
Right.
PANCE and PANRE, I think is what PAs take.
Correct?
Yeah.
Okay, we do have one, we did have another hand raised, but now we have Kelly. Do you want to go ahead and comment, Kelly? Hold on. There you go.
Thank you. I was trying to put in the chat, my mic was disabled. And I just wanted to clarify, and we put some extensive notes in our comment from our association as well. But there was a lot of negotiation on bill language within the House Healthcare Committee during this last session. And the concern that we had, because an AA is able to take their certifying exam even before they graduate from their program, there is not any kind of built-in delay for them. It is not at all the same as for a physician that needs to practice for a period of time before they can be board eligible. They are board eligible before they even complete their program. Because this is a new profession here, we discussed the safety of having somebody who had not proven just their basic standard of care through their certifying exam, which all CAAs have to be certified, the same as all nurse anesthetists must be certified. It is a completely different picture than the physician side of things. To allow them an entire year to practice on an interim permit is not in the interest of public safety. And there was an entire section in the original bill that was titled temporary licensure, and that was expressly pulled out. I have email documentation from Representative Riccelli, who was the chair of that committee, as well as staff from that committee, which I put some quotes from in our commentary as well.
Thank you, Kelly. And then Jeff? Oh, hold on. Let me try to unmute you. There you go.
I'm sorry, can you hear me now?
Yes. Apologies, it
everyone.
was my fault.
Hi, apologies for that. I'm Dr. Jeff McLaren. I'm an anesthesiologist and I part of the WSSA board. My question is just, is it the same? I would establish the same for PAs and CRNAs. You know, these are people who are working under physician licensing. So the people who are supervising them are licensed, are certified, are board eligible. I think if this is similar to other providers like PAs and CRNAs, then I don't see why it would be a problem. Thank you.
Thank you. So as mentioned, I think Heather's going to go back and do some research, and then we will discuss this further at the next workshop. So I think we can move on from this
Amelia?
section for now. Yes, go ahead.
So just to be clear then, the person we're talking about, they would not be a certified anesthesia assistant, because in our definition, to be certified, you have to have taken the exam. So now this is now language about a person who isn't meeting that definition, just so I understand the whole thing. I'm not criticizing or commenting, just to say it's different, right?
There's two titles, Dr. Curry. There's the certified
Okay.
anesthesiologist assistant and then the anesthesiologist assistant. And so the certification
Okay.
comes once you pass the certified exam. Certification exam,
Okay.
sorry.
So this interim permit would be for an anesthesia assistant, not, got it. Okay. So they couldn't represent themselves as a CAA. It's a different sort of
That's correct.
thing. Okay, thank you.
Okay. So we will come back to this entire section at a later date. All right, moving on to the background check temporary practice permit. Any comments or questions about this piece? No one? Right. Moving right along then. So this military spouse section is from another bill, and it is pretty much copy and paste from the MD and PA. sections, which we have made some changes to that were just approved on Friday. So I will make sure that those changes are added in here. Because we removed the language for state registered domestic partner. So I will add that language in here and we can discuss it further at the next one if we want to. But besides that, we've already approved the changes to the MD and the PA section. So this will mirror that, except it will talk about CAAs instead.
Sounds good.
Amelia, in one, did we remove 1B, left employment?
Right. So this
okay.
is not
Yeah.
updated since
Gotcha.
Friday. So
Okay.
yeah, that's why
Sorry.
I'll go through and clean this up and make it identical to the
Perfect.
PA sections that were approved last week.
And to respond to Kelly's comment, number one is, as Heather Carter said, all professions under the Uniform Disciplinary Act, which is every health profession that's licensed, has the ability to do a criminal background check temporary permit. Second, the language direct deviation comment doesn't apply to other states. We have to make rules based off of our state statute, not others.
Thank you, Micah. All right, moving along. It's a very long section. Okay. Exemption from licensure qualified physician assistant pathway is the next section. Does anyone have any questions or comments? I mean, obviously, I'm going to fix this 1B to where it says the right thing. Ed, do you have any feedback on this section?
No, I think it's a very reasonable approach.
I have a quick question about, so this part doesn't have anything about like a practice agreement or anything. Is that because they don't need that because it's all like
They
direct
can't do a
supervision?
practice.
can't,
I mean, they
right,
have to be medically directed. I mean, really, that's
Right.
how they work. Yeah.
right. But
So-
do we need to know what group of physicians have agreed to direct? I get that there has to be someone there, but I just didn't know if we needed to like say who it is or what group it is or any more about that, like we do for say PAs or it's just a quick question. That's all. If we don't, we don't. That's fine.
No, so the bill doesn't speak to any form of practice agreements. It speaks to direct supervision. And so because of that, there's, well, I mean, the function is basically this is an employment role and it's their responsibility at the actual physical site to make sure that the supervision is occurring correctly. And as people have noted, with respect to CMS reimbursement regs, it would also be, their malpractice liability if they were not to supervise in an appropriate way.
Right. Okay. Thanks.
And as far as, and I'm going to respond to a comment talking about listed at least 2 years in length. I believe the bill is specific to being accredited. So we don't have to specify what the length is because we're relying on the accreditation.
Okay.
And Kelly, for your 1C suggestion, are you talking about this section here or about the PA pathway for not having to get an additional license?
She's talking about this one that we're on, I think. 125?
I just want to
Yep.
confirm that that's what we're talking about.
Yep. Okay, so the suggestion is to add under 1C that they would need to maintain their AA certification. Meaning they would have to keep up their anesthesia-related CMEs.
That seems like a good suggestion. Is that sort of like when we do our maintenance certification for our specialty? Is that an analogy?
There's actually
analogy?
there's actually a CME maintenance of certification section in the rules here that we're dealing with. So, I mean, I would defer to Heather on the interpretation. The assumption is that if you're a PA who went through an accredited AA program and got your certification, everything in this section would apply to you as far as your practice and your requirements. Is that an accurate assessment of how this would work?
Yeah, so if you've received your CAA license from Washington, then you comply with these rules.
Yeah.
Is that what you're
Well,
saying? Yeah.
Well, this is specifically exempting them from the CAA license because they have a PA license, and the PA statute has a pathway to AA practice specifically, or not statute, I'm sorry, in its rule, has a pathway to AA practice by completing a accredited program and completing the certification exam. So that's what this section is speaking to.
Right. And your next section says that they're going to be supervised according to these rules, the CAA rules or the AA rules. Is that right?
Yes.
Yeah. Yeah, I agree with that.
So we don't need to add anything here?
I think the request is to clarify that they have to maintain their certification with I don't even know what it is anymore. Whatever their CAA certification if they are in this pathway.
So are we adding that under 1C?
Is that, to Heather, is that necessary? Or, I mean, I'm fine with the concept of clarifying it. It doesn't seem to be extra. It's just a clarification. The assumption was.
I think that's fine.
Okay. Hold on, I have to scroll now.
Sorry.
Apologies. That's my fault. I didn't send my comment. Okay. So we need to add language here about maintaining.
And just to be clear, the assumption, and based off of what Shane's comment here, is that they would have to maintain it anyway, and that would require anesthesia specific CME in that process. So I think it would just be has successfully passed the certification exam offered by the NCAA and maintains said certification.
Reading the comments. Okay. So are the comments cleared up now? Or we're addressing them in some way? Any additional comments about this section?
So just making sure that it's not about maintaining AA CMEs, it's about maintaining the AA certification. The CMEs come with that. So they have to maintain their CMEs in specific areas to maintain the certification, as I understand it.
Okay. Okay. Anything else on this section? Do PAAs need a collaborative agreement? I believe earlier we spoke about that no, they can't have a collaborative agreement.
If they were practicing in the capacity of a PA, they would need that. But if they're practicing under the capacity of an AA, the rule that's proposed is clear. The AA chapter applies to them, and therefore they would not because they're under direct supervision.
Right. Okay. I think that's one of the questions we're going to need to include on our FAQ.
Mhm.
And when we do any sort of education about this new profession, I think that's an important question to have answered and have information about. So
Yeah.
just make a note of that, Micah and Marissa. Okay, moving on to renewal, continuing medical education cycle, and maintenance of licensure. Are there any comments or questions about this section? Which Micah has nicely broken out.
My only
This is all about
comment,
renewal.
my only comment
Go
is to Heather, is it okay to have it broken out like that? Because it was getting long and difficult to sort out as we're copying and pasting.
The license renewal.
Right,
Yeah,
so
so
he's
under,
got like these
yeah, go ahead.
headers. And it's similar to what we have in the PA license. We have these little headers that break out a section.
Oh,
Like this part of it's license renewal. This part of it is maintenance of licensure.
yeah, I see what you're saying. So I know some rules have that, but I'm not sure if the code revisor is letting people do that anymore or not. So
So
we'll have
maybe
to look
that's
at
a good,
it's a style thing more than anything,
Mhm.
really. So we'll need to look and just make sure that they'll allow that, because they are nitpicky.
so that's a good question for Marlon. You don't have to answer it right now, but just keep that in mind.
Yeah, no, I agree with Heather. I think that's a style thing we would have to consult with the code revisor on.
Okay, thank you. All right, so any questions about this long section or any additions or suggestions for language changes?
The only thing I would point out is I did say maintenance of licensure or something like that.
Mhm.
I know that can sometimes be viewed as a term of art, but given how we have it named in the physician statute, that's the reason I went with that. But if people think that that's not okay, or we need to change that, I'm totally open to whatever we need to do.
Any
I was
comments
fine
on
with
that?
it.
Micah, on section 8 and 9, where it talks about like the type of CME who accredits, is that all taken from PA or MD type rules? Sort of all this language?
Yes,
Okay, thanks.
but I do believe that the whole ACCME concept still applies. They do funnel down through various providers nationally and in the state, including us, by the way, for offering accredited CME.
Mhm.
And yes, to
Okay.
your point about the section 9, that is a direct copy. I see an issue. Sorry, I missed a physician assistant at the last sentence in that section. That should be anesthesiologist assistant.
Oh my God. You're fired, Micah.
My find and replace skills are not what they once were.
Okay. Any other comments or questions about that section? None.
I just have to say, I
So,
love the meritorious learning experience. Meritorious. I never thought of my learning experiences as meritorious.
I wish I
That's
could
awesome,
take credit, but can't do it.
Sorry.
okay, so this next section is based off of a bill that came through a long time ago. This is in every healthcare profession's whack. So this is probably a direct copy and paste from either the MD or PA. And unless we ever make changes to those others, then this one it has to be written the way it's written. So, I mean, you can, of course, submit comments. We can consider them. but yeah. And it's a one-time training. So,
And as far as addressing the last component of limited patient contact, I don't want to speak for the legislature, but they had the opportunity to exempt certain groups and professions, and anesthesiologists, physicians were not exempted at that time. So I think it's reasonable to assume that CAAs would not be exempted either.
because they do have brief, right?
I mean, I don't
What would
think
be
you can
considered
do a
brief
mental health
contact?
assessment during that brief contact, but yeah.
Right. I mean, I wouldn't think so either, but yeah. And we've talked at length about why we can't exempt specialties within the MD rule. So, yeah, we keep in the brief, limited, or no patient contact. And please don't send us an attestation of your completion of the training. And all these that have XXX, I will fix later. I just added these numbers last week, the last dash number. So, okay. And again, this section, health equity, continuing education training requirements, is from another bill. And it's a requirement for all health professions. So we won't be making any changes to this. I'm assuming this was directly copied from MDs or PAs. Okay, retired license. Does anybody have any questions or comments about retired license?
And again, this is the retired status piece has been in existence. I'm probably gonna get this year wrong, but I want to say it's somewhere in the 2008 range, and it's uniform across all of our license types.
It looks like no questions. Thank you for that comment, Micah. I think this section is similar, returning to active status when a license has expired. It's something that we've had established previously for our other two license types. But does anyone have any questions or comments about this one?
We have a question about the retired C and D number 1, which I don't remember what those are.
Let me go back. Okay.
We'll have to look into what. So that's not our WAC, Kelly. It's the,
Right.
That's the
Critics
secretary's
12
WAC.
class.
So this is a copy and paste. So I'll need to see what it says there.
And while I'm looking at it, I have the thought they do need a supervision arrangement. So like a practice agreement when it's a retired license. And we mean that, right? For this situation?
Mm-hmm.
Okay.
Yeah, number 2 addresses that.
Right.
C and D are the emergent circumstances and intermittent.
Yeah. Emergent, and then no more than 90 days a year. That's C.
So to the C and D, someone D Bender comments that those 2 things are later included. So why exclude them? That's a great question. Because I copied and pasted is really what came down to it. So we'll look into that and see and resolve the conflict. It may just be deleting that exclusion piece. And I missed something. 4B is the next question.
4B. I think that was in reference to what we just talked about.
Okay.
In emergent circumstances, intermittent.
Okay. So we're resolved on that one then.
Yeah, I'll look into this one a little further and maybe change up this language a little bit. And that's something we may need to do in the MDMPAs too. I don't know.
There, I will say, just to let everyone know, there is an intent on the part of myself and Marissa to revise the retired language in all of the rules. Because currently, if you're not familiar, there's 4 different flavors, and it's a little bit ridiculous. So we're going to try and collapse it into just a single retired status and simplify it.
I agree with that. And our MD chapter, excluding the opioid prescribing rules, will be open next year. So we can make those changes then. Okay. 4B. So there's a comment on 4B here. It says that is very vague, allowing a wide variety of practice for these individuals.
The same commenter said yes, thanks, after I thought we had resolved what was in here.
Kelly?
I thought it was referring to the exclusions and then the not exclusions, but
Nope.
perhaps that's
The thank you's not from Kelly, and it was Kelly that commented about 4B.
she says yes, thanks under D. Vendor.
Oh, okay. Oh, okay.
I
Thank you, Kelly.
apologize. I just assumed Kelly's gender, but if you're not that, I apologize.
Okay, and then this one is about an earlier section. Okay. I will make a note of that, Andrea. Since we've moved on from that section. I'll write that down. Okay, moving on from this section, unless there's other questions. Okay. And then returning to active status when a license has expired. And again, this one's similar to the MDMPA language. Questions, comments? Moving on. And the same is true of this section. This anesthesiologist assistant identification is something that is also in the PA chapter. Is it an MD chapter?
I think it's part of the statute as well. It was also a request in one of the comments.
Okay, under 2. So there's a suggestion in the comments that recommends number 2, an AA must not present themselves as an anesthesiologist, any other type of physician, nurse, anesthetist, or in any manner, which would tend to mislead the public. So I think this sentence is the same as what's in the PA, correct? It doesn't mention not identifying themselves as a physician.
Correct.
I think we need consistency with PA rules.
I would agree.
I think number 2 gets to what the commenter is talking about. We don't need to specify every license type under the sun to do this.
Right. Well, I mean, if we did, we would have already done it in the PA. Oh, he put his hand right down. Oh, back up. Hold on, Jeff. Go ahead, Jeff.
Yeah, I think if you want to address truth in naming, that's probably a bigger discussion than just in this piece of legislature. So if we want to talk about misrepresenting titles, that's probably something that should be looked at for all specialties. So I don't think this piece of this documentation needs to be the only one that calls that out.
Thank you. Yeah, this is a direct copy, other than anesthesiologist assistant, from the PA back. So, okay. So commissioners, you're fine with leaving this as is, number 2?
Yes.
Okay, mandatory reporting is similar, like we're just referencing the WAC that covers this for all professions. So we're not making any changes to that section. Okay, practice limitations and group supervision models. Questions, comments?
This was confusing to me because it talks about a supervision agreement, which I thought we said we don't need. So
It says supervision arrangement.
arrangement.
Yeah, so I
Okay.
believe that's actually directly, well, this I believe is actually directly copying the bill. So it's a copy paste of this, of that
got it.
section.
Okay.
And I guess I didn't articulate how we kind of designed this chapter. I'll just say that we don't, it's a rare, I guess, opportunity is how I call it, to create a chapter and organize it the way that makes sense. For references on how that doesn't work, look at our PA chapter. And so the principle behind the design of the chapter is really we wanted a CAA or an anesthesiologist, physician, or whoever else needs to reference this to be able to come to this chapter and not have to skip to anywhere else, or if they do, like the mandatory reporting or the reactivation piece, there's a link there to just take them directly where they need to go. So you should be able to kind of one-stop shop this as you're reading through, and it should be coherently organized. So that's the principle in organization and drafting here.
Which I am grateful for, Mike.
It makes sense. It just threw me when it said that the supervision arrangement doesn't need to be filed with commission, because that hearkened to the old practice agreements, which did need to be filed in the past for PAs. That's why I was, I think, stumbling over this particular piece, but I get it.
And again, this is directly what the statute says. It doesn't say that they're required to be filed, and I'm not sure that legally we have standing to go beyond the requirements of the statute in a rule, and Heather can clarify on that.
Yeah, I would agree with that. I would also say I don't see anywhere where it says it needs to be in writing. So I think you're right. Generally, can't require them to file something, and the statute requires it.
Yeah, and to be clear, we've already gone away from that with the PAs back in practice agreements. They keep those at the practice level. It's an employment function, and it appears that the drafting here for this bill is the same intent.
I like this section. I thought it was excellent.
Sorry, I'm making some notes. Okay.
D, you're mentioning 2A. Could you give some context other than just citing it?
She probably hit enter too quickly.
Oh, okay.
That'd be my guess. Or they.
I'd like to say that, never mind.
Okay.
Again,
They say
this is a
anesthesiologist.
direct,
Oh, you can read it. Sorry.
Yeah, I can read it. Again, this is a direct copy and paste from the bill language. So the concept that we can be more restrictive with our rules than what the bill is offering is a difficult legal proposition there.
Well, Carolyn states the statute specifically gave authority to the anesthesiologist to delegate. The commission cannot remove this.
D, if you're talking about CMS regs, what you're talking about are reimbursement requirements for CMS billing. That is not the same as practice standards, requirements, or standard of care.
I'd like to agree with that.
Yeah, this is Heather. The
Um,
commission doesn't have authority over billing or reimbursement, so.
I had a question just sort of to address some of the comments that we got. I think it's B, where it says administering and assisting with pre-op consultation. Would that be interpreted as including informed consent? Because there was some concern about informed consent, and I don't know whether we want it or not want it. I just wanted to bring it up to address the comment about that. So that was in B.
I'll defer to clinicians on this one because I have no idea.
Karen, how would you?
Generally, the supervising anesthesiologist obtains informed consent. They can talk about it, just like a nurse anesthetist could talk about it as well. But if you're working in a care team model, it's up to the anesthesiologist to also go through that. That's for medical direction though, and not generally supervision. I didn't see any problem with preoperative consultation. To me, is one of talking to patients.
Fine. I just wanted to be sure that we addressed the concern. And then there was another concern about establishing central lines and stopping and starting oxygen and respiratory therapy and things. I don't know if we need to address those comments. I think central lines are not in this, if I recall.
They can do whatever is under the direction of the supervising anesthesiologist. They don't need a delegation agreement.
I know, but I just wanted to address the comment like that maybe they shouldn't be doing that, although I think that's
Why
fine.
shouldn't they? If they're trained
Yeah.
in it and they're specializing, say, I mean, we hardly use central lines anymore,
Right.
except in certain circumstances. And if they're trained and say they're working in cardiac cases or something where they do see them and they're under the direction with someone there with them, putting it in with them teaching, I don't see why it needs to be called out.
I don't either.
Yeah.
I agree. I just wanted to make sure we address the comments we received.
Then we have 2 hands raised. So Jeff, you can go ahead.
Thanks, everyone. I think to Dr. Domino's point, under medical direction, if someone is placing a central line, that would be considered a critical portion of the case. And by definition, I would have to be there to supervise that. So while they may be helping in actually performing the task, it's under my direct supervision. Similar with informed consent, the question about that is, yes, you know, in my care team models, anyone I'm working with, our CRNAs may discuss what's going to happen, but ultimately it's my decision and my discretion and my discussion with the patient about going forward with the anesthetic. So they certainly, like our nurse anesthetists, are great and provide opportunities and education to our patients all the time, and I'm there to help reinforce that and make sure all questions are answered before they go back to surgery, which would be similar to this model. So I don't think it needs to be removed.
Thank you. And then Amy. Amy Brackenberry. Says you're self-muted. I have unmuted you. Why don't you go ahead, Ed?
Yes, I'd like to remind all clinicians here that, as we all know, the extensive list upon the credentialing process for hospital credentialing, there is verification, there's a list and a verification of what procedures a person is capable of doing, either by training or experience. And so when they do accept credentialing or hospital privileges in the hospital, there should be the assurance when that anesthesiology or anesthesiologist assistant is employed that there should be some certainty to know that the person that's working there is capable, if it's a central line or not a central line or any other invasive procedure, that it has been verified by the credentialing body of the institution.
Thank you. Thank you. Looks like Amy's having trouble unmuting. So I'm just going to leave her mic available. And Micah has asked her to type her comments. So from the commissioners, are there any other issues with this section or any other parts you would like to discuss? Oh. So Amy says she was going to echo Dr. McLaren's comments. And then we have Dee Bender. Your microphone is enabled. You're able to unmute. On my end, it says it is. It says it's self-muted.
Maybe the comments can just be typed.
I'll leave your mic open. Oh, interesting. Amy says on her end, the mic button is grayed out and not allowing the option to unmute. Interesting, because other folks have been able to. And Katarina Lamarche from WISMA says, or from WISHA, sorry, says they concur with Dr. McLaren's comments as well. He is trying to tell us that there is contradictory language in the statute. Do you know what they might be referencing, Micah?
So this is going to be awkward. I'm going to speak, and Dee, I'm going to ask you to respond in the chat. So are you talking about the statute itself contradicts with itself, or the statute contradicts with something that's not in Washington statute? Dee, I apologize. I'm having trouble following. So are you saying that
I was thinking
1871D?
it's number 4.
Okay.
An nothing in this section should be construed to prevent an anesthesiologist assistant from having access to or being able to obtain drugs as directed by the supervising anesthesiologist. And then the next set says an anesthesiologist assistant may not prescribe, order, compound, or dispense drugs, medications, or devices of any kind. So that seems is a little confusing. D, is that
Yeah.
the right one? Sorry, you come and go. So
Yeah,
She said-
D. Sorry.
They're saying yes, that it is the right one. Good job, Dr. Domino.
So that language is directly from the statute as well.
Mhm.
What were they thinking?
I don't know, maybe the thing is it's access under the direct, as directed by the supervising anesthesiologist. So as an example, I, for instance, often order phosphenotoin, and I don't do it myself. Okay, I ask our resident or CRNA to do it, or so that's under my direction. I know it's confusing. I don't know.
Can we see the top portion that talks about the access piece?
What are you referencing, Micah?
Because I think that what they were talking about talks about ordering meds, and so I'm trying to see that.
Right. So it says it's this section 4 that's on the screen. From having access to and being able to obtain drugs as directed by the supervising anesthesiologist.
And now we're being told that
But they-
2C is where the conflict is apparently.
2C. Oh, I apologize for the scrolling. Two C. Oh.
Yeah, it's a little vague on the timeline here.
So we're
I'm
getting
not sure why they have to be co-signed for controlled substances. A lot of times for a recovery room, there are standing orders that are often just even someone who's not licensed, like meaning a resident, orders. And
so, Dr. Domino, we've got some I would just say conflicting comments. Some people are reading this as order, meaning they prescribe. The others are saying that it's the supervising anesthesiologist that prescribes, and the AA can call down and order the drugs based off of that, or have a cosign later as I'm reading this. And then we've got another comment. This clarifies that the CAA can only order meds to be used at the facility, and this was something that the CRNA has requested be added in.
yeah, I thought that the at the facility seemed fine, but they, to sign standing recovery room orders, which does include pain medications. I would be surprised why they would need to have a co-signature.
So I think what I'm going to ask that we do on this one, for if we just make a note on potential conflict, and we can take it back with our legal team to include Heather. Sorry, Heather. And and I think this really does seem to be coming down to the concept of order versus prescribe, and we'll need to get a ruling internally before we move forward.
And the last part of this, Karen, does say that it's only if it's required by the facility. So it may depend on where you're practicing.
So take it back for some more research, Amelia. All right.
Yeah. And you're right, Dee, it does say. So We'll be looking further into these two. Sorry for the scrolling. Okay. So we'll deal with 4 later. So we can move on to the rest of this section. Do you have any issues with 5?
Pretty sure that's straight from the statute.
And I know there's some question about 6 for sure, the 4-to-1.
Amelia, that's in the statute though, right? That was the,
That was your question, and I'm not sure.
Yeah.
So
I think that's what I was told. Heather said.
Is
Yeah,
the
so it's-
more than 4-to-1 in the statute?
if we put it in rule, we can have more than 4-to-1, otherwise.
Yeah, that
it's
seems
4-to-1.
excessively high. I don't.
Yeah, I thought 4-to-1 was plenty. If anything, there was concerns it should be less, but I think we can't make it less, so.
I think there's consensus in the chat that the statute says no more than 4. And then Amy with wishes supports the maximum 4-to-1. Okay. Any other questions or comments about 6?
I want to clarify Kelly's comment. That is not correct. So it says, unless approved by the commission, an anesthesiologist may not concurrently supervise more than 4 specifics. So if we get a request, we can approve it, but there's specific items listed in here that that require answering before the commission will consider a request.
Which is similar to what we used to have with the PAs.
Right. I mean, it's a very familiar model.
I guess I'm a
again-
little concerned with it because it is different. I mean, yeah, they also may not. I'm just worried about some individuals who may just want to pad, I mean, they can't really adequately medically direct in this supervisory manner with more than, really more than 4 sites at a time. I mean, that's almost impossible to do all the things you have to do. So.
Right. So, I mean,
Yeah.
the drafting is such that the standard is 4-to-1. And to address and provide some specific process, I guess is what I'd say, if we do have someone, because it's in statute, so I have to guarantee that someone is going to ask. And so in learning from Heather and her wisdom, we at least have to have a process laid out that is defensible, that we can use to review and or deny.
So it is in statute?
Yes.
More
Yes.
than 1?
Yeah, so in 030, it says, unless approved by the commission, an anesthesiologist may not concurrently supervise more than 4 specific individual anesthesiologist assistants at any one time. So it does set up an approval process.
Right. So that's what this is trying to address. It's not trying to create more than a 4-to-1 ratio. 4-to-1 is up to the institutions on how they want to deal with that, if they even want to go up to 4-to-1. But again, because it says unless approved by the commission, I assure you we are going to get a request. So we have to have a process that's defensible in rule, so we can use that and rely on that.
I mean, I suppose they could be used as, like nurses in preoperative clinic as an example, where you have, perhaps in that area.
Yeah. And to address the comment, yes, there are billing implications that, we're not too concerned about that aspect when it comes to the regulatory structure. But again, that I think that's an outside the regulatory structure limiting factor that folks will not go above the 4-to-1 ratio due to billing. So, I mean, you're not going to want to practice and not be able to get paid.
Mhm.
And with respect to Kelly's comment, I don't agree with that interpretation. It says 4-to-1, and unless requested, you can go higher. It doesn't say that we can limit down to 2-to-1, 3-to-1, or 1-to-1.
Thank you for that, Carolyn. I'll make a note of that. Okay.
And for the commissioners on this one, if we could just look at 6A through whatever they are, and also a question to Marissa, because I know she's on here. I've got a 7-day review built into this section. So if we receive a complete request, we will we're basically committing that 7 business days we will have a response back to the requester. But then for the commissioners, my question is for A, B, C, and if there's another one down there, D. Is that what you would want to see in a request about ratios, or is there something else that you would want to see?
I mean, I'm just concerned if they're doing operating room activities or non-operating room kind of cases. It's different than, say, if they're doing a screen, like, in contrast to a nurse, a regular nurse generally, who's working in preoperative clinic, or if they're seeing, maybe in certain pain medicine practices where they're maybe screening patients. I don't know. I just think they can't really practice more than 4 to, 4 of them to one anesthesiologist doing anesthesia cases. Okay. If they're doing some other stuff that we all do, like, as I said, pre-op clinic is something for centers that have pre-op clinic and attendings and large groups of nurses to do it. The pre-op, basic pre-op. I don't know.
So I think
Yeah.
the questions that Micah has here, sort of that they would have to answer, would require the information, would get that information, Karen, so that if it was, no, we just want to run 8 ORs and have one MD supervise 8 ORs with, CAs, obviously that request would be denied, right?
Well,
So they
I
would
wonder
have
if
to
we need a
really,
statement about it. I mean, I know it's better sometimes to not say anything, but I'm worried about kind of unscrupulous, docs who want to make a lot of money and don't want to do that. Yeah, I mean, that's all. To me,
like a
it just
surgery
seems,
center or something.
yeah, right.
But I think we
again,
can
I was just
deny.
hearing like from my husband who was in practice, he was telling me about some guys who were ultimately convicted of Medicare fraud, but trying to run like medically direct while there are many nurse anesthetists while being in the room themselves and unavailable and not meeting those requirements. And there are people out there, sadly, which I do sometimes see in my role on the commission, that I wonder if it needs to be specified a little more. Anyway, I know sometimes it's best not to say anything and just have it happen at the commission level, but anyway, that's my worry.
So, Micah, is 7 days enough? For example, if somebody made this request, went through this process, and you needed input, say, from Dr. Domino, is 7 days
It's
enough?
not enough. Yeah.
Yeah,
Or is that in
that's another,
statute?
Yeah.
I was gonna remove that and just be silent. I
Sure.
don't think you need to tie yourself down because you're going to need to take this to a panel
Mhm.
of at least
I was
3
gonna
to make a
suggest-
decision. And then we also probably want to add in something here, and Micah, you and I can talk about this. For if there's a denial, they get some sort of due process. So probably want to do that as a BAP.
Right. So saying add language about the BAP.
I'm thinking because I don't know that the secretary's model rules on BAPs is going to be updated anytime soon. We've been waiting on some other ones, so
Yeah.
maybe we just want to put it in here,
Okay.
but we can talk about that.
And for the attendees, just to be clear, BAP is called Brief Adjudicated Proceedings. Heather can probably speak more about the requirements, but it's a for all intents and purposes, it's a mini hearing. That's we can call it a paper trial, or where the facts aren't really in dispute, but there is a decision that does need to be made and some due process that is awarded.
So to just
Yeah.
back up a second real quick, sorry, you wanting to remove the within 7 business days, right?
Yes,
I would think
yes,
so.
please.
And then before we move on, Jeff has had his hand raised for a few moments. Go ahead, Jeff.
Thank you. I was just gonna comment. I agree, Dr. Domino. I think there are some nefarious people out there, and we want to try and avoid that. I would just say that I like the wording that the 4-to-1 ratio is our expectation without permission from the medical commission. Also, under medical direction, you can't bill more than 4-to-1, so it would be fraud, and therefore there's lots of repercussions for that. But I guess in a very extenuating circumstance, someone might actually request that, which I can't imagine, but maybe that would exist, and I think the commission itself would have the final say on that, which I think is reasonable.
But the
Thank
billing
you.
issue for 4-to-1 has to do with CMS rules, right? If I understand it correctly. So if you have a cash-based practice at an outpatient surgery center where you're running a bunch of ORs doing cosmetic stuff or whatever, I mean, that's kind of, that's the scenario I was thinking of, which I think we
Gotcha.
don't have those ratios required for billing.
Yeah, that's a great point. And I think, the WSSA certainly does not, we are not supporting anything more than 4-to-1. As everyone's mentioned, it becomes very, very challenging to do anything more than that safely. But I think you are right. In a cash-based practice, that could be very different. A cash-based practice running more than 4 ORs would be quite large. And I think they might have other regulatory issues at that point, but maybe not.
And again, the statute is clear. 4-to-1 ratio is the standard. And this is about addressing the language of upon commission approval, or if you make a request of the commission to go above that. So we're trying to make sure that there's a defensible process that doesn't put the commission in an arbitrary and capricious setting on making these decisions to approve or deny. As the testimony that we've heard from commissioners and commenters alike, everyone's pretty comfortable with the 4-to-1. I have a hard time seeing, if all of this is submitted, what scenario would be approved for more than a 4-to-1.
Okay. So, and Heather and Micah are going to work on this piece of adding denial due process information. Come up some language for that we can put in. Okay. So it is 4:50. Oh, sorry. Go ahead, Dr. John.
Yeah, no, I was just kind of reading through those sections 6A, B, C, and D, and I understand what it's trying to do. That if it's more than 4-to-1, that somehow there's a greater risk of patient safety. So you kind of want people to explain that there's a greater risk that standard of care may be violated. I guess it almost seems like, well, shouldn't you have that in place anyway? I mean, you know, whether or not you're supervising 4 or 5 or 3. And I'm not saying we need to change language. I'm just kind of thinking out loud. And the one that kind of makes me scratch my head a little bit is D, where what escalation and physician backup procedures are in place should multiple anesthesia and anesthesia, I guess it means anesthesiologist assistants, require the presence or assistance of the physician anesthesiologist. Again, I mean, it just seems like you should have that in place. I mean, that could happen even if you had two anesthesiologist assistants, right? Not just 5. So I understand the intent of requiring these things if you're going to request more than 4, but the way it's worded just seems a little bit inelegant to me, because it seems like, well, we want all of those things no matter how many anesthesiologist assistants you have, you know? And so, again, I don't have a suggestion. I'm just kind of thinking out loud.
Well, I'll take responsibility for the inelegant language. And as far as your comment, Dr. Chung, yeah, I agree. We assume this is already all in place in a 4-to-1 scenario. But the statute again says upon approval of the commission. So we want you to demonstrate in an above scenario what that would be and satisfy to the commission's requirements that those are there. So if there's more elegant language, obviously happy to consider it.
Yeah, I don't have a suggestion. I mean, you know, an anesthesiologist, a physician might face this scenario no matter how many anesthesiologist assistants they're actually supervising. So,
and I think the scope and limitations section does speak to that assumption about these are the things you can do, and the delegation pieces, and the assumption, I think, frankly, of the folks that brought this forward, how they would operate within a hospital system or other.
Okay, so it is 4:18 and we were going to pause at 4:15. So I think we will stop here at 7. Just make a note. And we will discuss we need to schedule some future workshops. Get that pulled up. Okay, so here is what our calendar looks like for the next 3 months. And again, if we look back at the timeline, we are hoping to propose that CR 102 at the January 10th business meeting. So we need to schedule, I would say, at least 3 more workshops. At least we'll have them on the books. So if you have any availability from, say, next Monday through the next 2 months, if we can get something scheduled at this meeting today, that would be fantastic for me.
My schedule is challenging, so I don't know if you want me to just give you my dates that I might have chance to make it.
Sure. I mean, if we can start, it's a
or
good place
how we
to start.
want to do it. All right. Monday, November 4th. I have stuff in the morning, standing meetings. The afternoon is okay. Friday, November 8th, after the morning, because I have a meeting all morning.
Okay.
Are we not meeting Veterans Day? Is that what that means?
Right. That day is blacked out because it's a holiday.
Boy. Possibly Tuesday, the 12th of November and the 13th. I do have to see if I got added in the OR for those
Okay.
days.
So the 12th and the what other date did you say
13th.
are maybes? And 13th
Tuesday,
are
the
maybes.
12th, Wednesday, the 13th.
Okay.
I may have a CMT in the morning on Wednesday. If sometimes I sign up on Wednesdays when I'm non-clinical, but
Well, I would not
feel not
schedule
sure.
these during.
Yeah.
Yeah, I would
I
not
think 'cause
schedule these on a Wednesday morning. Ever.
Yeah, we have our meeting on the 14th, right?
Mhm.
So
Yep.
I think the following week would be maybe a little better.
Better. How's your
Monday,
availability?
Monday, the 18th in the afternoon.
Okay.
Friday, the 22nd in the afternoon.
And then we won't do anything Thanksgiving week, I don't think.
Mhm.
There's gonna be so many people not available that week.
Friday, the 6th of December afternoon. Wednesday, December 11th. I think I'm okay. Monday,
No.
December 16th. Friday, December 20th afternoon. Otherwise, I can't do it.
Okay. So what I'll do is I will add all these dates to an email and send it to those of you that are on the panel today and see if you're available as well. Then I'll get a new schedule sent out, hopefully by Wednesday this week. And we will get the new draft posted at least a week before the next workshop. And it'll be posted on our rules and progress page.
Karen,
Okay.
for afternoon, can I ask you, do you mean like 1 o'clock?
Yes.
Okay.
I often
So
have
that-
meetings like those Fridays. I'm the institutional review board. It's like a 3-hour, 3.5 hours done. It could be noon even, but yeah.
Okay. So earlier usually works better for me, Amelia, for what it's worth.
Okay. Okay. Well, I can do them at 1. I typically do them at 2:30, but I can do them at 1 as well. So. All right. Thank you guys. And then.
Okay. Are there any questions? Can I go on with my script?
Yep. Go ahead.
Yeah. Are there any questions from attendees that have not been answered? Amelia, do you see any questions?
No, there's nothing in the chat. No hands are raised.
Okay. Well, thanks everyone for your participation and your comments. Ms. Boyd, please provide contact information.
It is very hard doing this with only 2 screens. So written comments about these rules can be sent to medical.rules@wmc.wa.gov.
Okay, I will now close the workshop and look forward to continuing our discussion of these rules soon. Thanks so much for attending.
Thank you, everyone.
Thank you.
Thank you.